I think we were here. There's a very slight increase in stroke risk with migraine, but only in migraine with aura. And I do want you to note the confidence interval there. It's just barely significant. We didn't cross one, but there it is. So there might actually be no increased risk. Once you take into account migraine without aura, completely gone. So maybe there's something there. But the role of the vasculature in headache, probably overestimated. We'll get into that. Some folks with migraine will remit. Whether or not that happens depends upon the severity, really. If you have fewer headache days, you're more likely to remit. So 15 to 19 compared to 25 to 31 per month. Sounds like a lot. The folks with fewer headaches were about only 30% likely to keep their migraine compared to those with a higher frequency. About a 70% reduction in their risk of maintaining migraine. And the absence of allodynia. So if you're not getting abnormal painful sensation from non-painful touch, you're more likely to remit. If you are getting those painful sensations, that suggests that there's a greater underlying disability, and so you're less likely to remit because it's a more severe problem. Cluster headache more commonly affects males. I think there's something in the book about them having orange peel skin and being 3 inches taller or something like that. Kind of interesting. These are painful. Cluster headaches are far more painful than the other types of headaches. They occur in clusters, so you'll get multiple headaches in a short period of time. And that sucks. Not surprisingly, there's an increased risk of depression associated with this and substance abuse. Certainly a family history is not a good thing. If you have a first-degree relative or a second-degree relative, your risk increases about 26-fold or 4-fold of confidence intervals. Pretty good. Pretty good heritability, not in every case, but there's usually, in about 20% of cases, an established family history of cluster headache, suggesting there's an underlying biological cause for this, and of course there is. It's not uncommon to see sleep abnormalities. Cluster headaches tend to occur more often at night. Excruciating pain does not help with sleep. Patients will often be woken up by this cluster headache. So here we can see the occurrence of cluster headaches, that would be the little arrows, occurring during sleep. That's what this is, believe it or not. So wake is up here as they're transitioning into slow wave sleep. That's down here. We can see there's this cyclic change. These look kind of abnormal. You're not getting a stepwise progression in every case. They're waking up from slow wave sleep that shouldn't happen. And sometimes they're getting woken up because of the headache. This is suggestive of some abnormality with circadian rhythms. And when you're thinking circadian rhythms, I know you're thinking the hypothalamus. We're going to be talking about the hypothalamus, not surprisingly, in this lecture and then next year too. They also have a higher apnea-hypopnea index. Again, sleep abnormalities. The symptoms would be those severe clusters of headaches, severe pain, mostly around the eye. With tension headache, it's kind of diffused around the head. Migraine is going to be more unilateral, sometimes involving the eye, but usually about right here. And then cluster is going to be more behind the eye. You will see autonomic changes as well. Sometimes they're bilateral, sometimes they're unilateral. What they all have in common is an increase in cholinergic signaling. Sweating is stimulated by the sympathetic nervous system, but these are very unique sympathetic neurons. They don't release norepinephrine. They release acetylcholine. Biology doesn't make it easy on us. All the rest of these are from parasympathetic output. Of course, postganglionic parasympathetic neurons release acetylcholine. So there's some abnormality in cholinergic signaling that creates sweating in the forehead, constriction of the pupils, drooping of the eyelid, that can happen, increased hearing, mucus production. And not surprisingly, the autonomic nervous system is regulated by the hypothalamus. There's a direct projection from the hypothalamus to preganglionic sympathetic, in this case, and parasympathetic neurons. The hypothalamus inhibits sympathetic output, which will mimic all of this except the sweating there. Because everything is a relative comparison. Do I have parasympathetic activation or sympathetic? Well, you could stimulate the parasympathetic nervous system or you could inhibit the sympathetic nervous system. Same thing. There's still that shift in cholinergic and noradrenergic signaling that's going to be sensed by the cells. Everything is relative in life. So it could be hyperactive hypothalamus inhibiting sympathetic output. It could be stimulating parasympathetic output. There could be mutations in muscarinic acetylcholine receptors. We don't know. But clearly there's some abnormality in hypothalamic function that leads to stimulation of the trigeminal nucleus. There's a projection there as well. We'll get to that. And these autonomic abnormalities that you see in cluster headaches. All roads lead to the hypothalamus for cluster headache. Of course, all headache roads ultimately converge on the trigeminal nerve. But we're not there yet. Cluster headaches suck. These are debilitating. Common for folks to lose their job as a result, taking days off. Employers usually don't like that. They want you there working. And if you have a headache, especially one that's severe, you're not going to do a very good job working. I can't think of any line of work where that would help. The relationship between cluster headache and depression likely underlies this increase in suicidal ideation that we see. So the quality of life is not great. Some cases do spontaneously remit. These possibilities seem about equal. About a third of them remit after a few decades. So if you deal with it for 20 years or so, maybe it'll get better. So maybe it'll be gone. Maybe there'll just be a reduction. Maybe there's no change. So they don't all remit. If you had to choose one type of headache, you wouldn't choose cluster. That's not the one. Do we have any questions? Yeah.
So if we think that the headaches aren't caused by the vasculature as much anymore, how do triptans work? Don't they target the vasculature?
They're going to target the trigeminal nerve. And the trigeminal nerve can certainly affect the vasculature. But triptans are going to act peripherally and centrally on trigeminal signaling. Excellent question. Yeah, the trigeminal nerve has serotonin receptors, and that's going to be the target there. And we'll see why we don't think it's the vasculature. But you'll still see that in textbooks. And if you read, you saw it. You saw it in yours. Any other questions? Okay, I got a few. Let's go through these. Please and thank you. Even the birthday girl has to do it.
Oh wait, where am I stuck? Necessary to treat.
What kind of apple is that?
I won't even make it. If I had, and they always are. Their name is not good. They are the worst apple out there. And of course, that's what kids get.
Yeah.
Honey Christmas. Anything else?
Sometimes, like, if I'm like putting them in like chocolate, real
Oh.
or like a dessert.
What's that? What chocolate? Hardwood press. Or like in a pot.
Yeah.
Oh. Sour apples.
Oh.
Oh yeah, yeah. But all your other numbers are right.
I don't know. I didn't see that. I don't know. Let me find out. What about her sleep?
Oh, okay. Well,
Now, are they clusters of migraines?
no,
Or is it
okay. She gets like the whole like eye thing.
Okay,
The reason
okay.
her sleep is invaded because my sister, my disorder and while he's up, like this whole thing.
Oh.
But her sleep isn't that great usually. I'm so glad I don't know.
I mean, it's not super surprising because they both converge on abnormal oxidation.
Yeah. I was just always funny. I mean,
Sounds like. Of course, we all are. All right. Do we need any more time? No. Going once. Going twice. Alrighty. Sydney. Do we have a Sydney Winstead in the house? Yeah? All right. Well, which one is the most common of these three types of headaches? Fantastic. Least common? Excellent. How about the location of pain?
The tension is like the headband, and then like clusters at like the eye,
Okay.
and migraine is on like one side.
Okay. The cluster's probably on one side, but yeah, you got it. Yeah. Which one is the most debilitating?
Cluster.
Absolutely. And which one can you probably live with just fine?
Tension.
Yeah, I'd say so. Okay, excellent. Thanks, Sydney. Okay, what is aura? Miranda.
Yes. It's warning signs before migraine, so it might include lowered mood or scotoma or tingling in the hands and face.
What's that second thing you said?
Scotoma.
What is that?
I don't know, what is that? Oh, it's like blurred vision with some colors.
There we go. Visual signs are common with aura. Yeah. Yeah. You might have some tingling in your hands. You might even have some hemiplegia. But visual signs are very common. Okay, good. And so these often precede a migraine. They don't always. Sometimes you don't have aura, and sometimes you have aura, no migraine. But they often go together. Okay, so that would be the additional symptom for migraine. Hopefully you all got that. How about cluster headaches? What do we see besides excruciating pain? What might we see in a cluster headache? Let's go with the other Sydney. Sydney Neal.
What was the question? I'm right.
Always good to start with what the next question is. What else do we see in cluster headache
Oh,
besides excruciating pain in the head?
sweating and tearing, nasal congestion,
Fantastic. We're going to see some sort of autonomic change. Might be unilateral, might be bilateral. So aside from pain, there's going to be sympathetic, parasympathetic activation. Mostly parasympathetic, it seems. Alrighty. Let's talk about how the pain gets produced. And when you're talking about pain in the head, you should be thinking trigeminal nerve. The trigeminal nerve is going to provide nearly all of the sensation for your head, whether it's painful or not. We shouldn't be thinking about vasculature. This idea is, it was great. It was great, as long as you don't consider the facts. And then it falls apart. But it's a really nice idea. You get headache because there's dilation of the vasculature in the meninges, and well, that causes some swelling, and then nociceptive afferents pick that up. And doesn't that just make a whole lot of sense? It's just a warm, comforting idea. But it's not true. So what we're looking at here are the, in this case, meningeal arteries. This is a magnetic resonance angiogram. We can see blood vessels in the head without having to open it up. It's pretty amazing. MRI is some wonderful stuff. You can look at the vasculature within the brain and the meninges, and you can see how they change during migraine. Let's do it. What do you say? So they recruited folks with migraine, and they gave some of them nitroglycerin, others placebo. Those that got nitroglycerin, some of them had migraine, some of them didn't. So we're looking at vascular diameter. We're going to look at a few different blood vessels. We'll highlight it over here. I'll tell you what it is. Baseline, so before any treatment, where are they clustering? The circles are going to be nitroglycerin, and they got a migraine. The triangles, little lighter, more of a dark gray here, nitroglycerin, but they didn't get a migraine. And then the very light gray with X's, placebo, no migraine. After they gave them either placebo or nitroglycerin, you can see both groups that got nitroglycerin had vasodilation. It worked. Of course it did. When imaged during the migraine, if they had it, or 6 hours later for those that didn't, they gave up on them. Is there any difference in the size of their blood vessels? No, not at all. Well, maybe we're looking at the wrong one. Let's look in. Let's look at the middle cerebral artery. Oh shit, looks the same. Exact same thing. Nitroglycerin causes vasodilation, but then it goes back, and you can't tell someone who's having a migraine from someone who's not by looking at their vasculature. Same thing for the posterior cerebral and basilar arteries. No difference. It's not about that. It's about abnormal signaling in the trigeminal nerve. And this would make a whole lot of sense if it were true. But don't think about vasculature. Think about abnormal trigeminal signaling. All right, we're going to try to trace very quickly the trigeminal thalamic tract. I've said there are 3 tracts that you need to know. This wasn't one of them. Moral of the story is don't listen to me. This is very similar to the spinal thalamic tract, though. It just arises from the face rather than the body. But it hits the same part of the thalamus, pretty much. So we'll call it the same thing, just to not make a liar out of me.
The trigeminal nerve is going to have a few different branches that are going to innervate the upper, middle, and kind of lower parts of the face. They also innervate the dura. That's not shown here because it's inside this guy's head. But right here, we're going to have the trigeminal nerve innervating the dura of the superior fossa. Not down in the brainstem, but up there in the cerebrum. It's hitting there too. These are the primary afferents. That means they're the first one. We only need to think about 3 neurons. Any more than that, I get confused. The primary neuron actually innervates the skin, musculature, connective tissue of the face, and dura. So they are out there sensing whether or not there's tissue damage. Now what tissue damage looks like is usually a drop in pH. There could be a change in heat. Oftentimes hot things hurt. Nociceptive afferents are sensitive to that. And there's a variety of neurotransmitters that can affect the activity of the trigeminal. Serotonin is brought up for good reason. We're going to talk about that later. The secondary neuron, that's going to arise from the spinal nucleus of the trigeminal. This extends over a very long period. I'm sorry, a very long span of the brainstem, and actually dips down into the spinal cord. Hence the name spinal nucleus of the trigeminal. There are a few different nuclei for the trigeminal nerve. We'll get into those next semester. Don't worry about them. For this lecture, we need to know the spinal nucleus. This handles nociceptive and temperature information. So all pain goes through the spinal nucleus. This is why tension headaches, which are created from muscular tension in your shoulders and neck, are going to still activate the trigeminal nerve. They're going to innervate the spinal cord. Spinal nucleus is down in there. Secondary afferents project from the spinal nucleus up to the thalamus, in particular the ventral posterior medial nucleus, but also the interlaminar nuclei. I know what you're thinking. That's going to cause widespread cortical stimulation, and you're totally right. That's going to wake you up whenever you have painful stimulation. If something is hurting you, you probably need to address it. So it makes sense that painful pathways are going to cause widespread cortical activation. But in order to localize the pain, they project to the ventral posterior medial nucleus of the thalamus, which then projects to the primary somatosensory cortex to say, where are you hurting? These would be the tertiary neurons. So 1, 2, 3 neurons. The first neuron's out there in the face, feeding in through the trigeminal nerve to the spinal nucleus. The secondary neuron goes from the spinal nucleus up to the thalamus, and that tertiary neuron is the one that's going to help create the perception of pain by projecting to the cortex to influence activity there. So there's our pathway, pretty straightforward. For the most part, we're going to be hanging out here in that primary neuron. That's where we're going to actually stimulate headache. So, TNA, trigeminal nociceptive afferent. That's that primary neuron. The one that's out there in the face and in the dura to pick up on pain. Here's pain. Here it is in the cartoon world. We got a sliver, in this case. Those usually hurt. Hopefully you don't have this in your meninges. But that's going to cause tissue damage. That tissue damage is going to be picked up by nociceptive afferents. So when intracellular components start spilling out from tissue damage, that's going to stimulate them. We activate our primary afferent. It's going to feed in to its secondary afferent, and then we're off. This is the spinal cord. Same idea, just different area. Primary, secondary. The primary picks it up. But it doesn't act in isolation. Have you ever noticed that when you have pain, it doesn't just last for that long? It usually sticks around for a little while. There are many reasons why that occurs. So out there in the periphery where there's actual damage being picked up, whether it's real or not, the activation of this primary afferent is going to cause local release of neurotransmitter. It's not going to be your typical glutamate. It's going to be a neuropeptide. In this case, substance P or calcitonin gene-related peptide. CGRP is what we're going to call it. That local release of neuropeptide is going to stimulate immune cells. Now, if you're out here in the finger, you'll probably find yourself a little neutrophil. But in the dura, you're going to find mast cells. They're more in the connective tissue. Same thing's going to happen, though. Local release of neuropeptides is going to stimulate the release of histamine from these immune cells. That's going to help promote inflammation so we can clean up the damage. But it's also going to stimulate the primary afferent to prolong its activation. So the immune cells are going to provide additional excitatory input. This is what we call the axon reflex. So the axon itself is going to detect the damage, spit out substance P in this case, to stimulate immune cells to further drive activation of the axon. So it's a little closed loop right at the site of damage. This prolongs nociceptive signaling. This allows that primary afferent to remain stimulated for a longer period of time because it's driving a positive feedback loop where when it's excited, it excites the immune cell. Excitation of the immune cell further excites the primary afferent. This way, pain lasts longer, and it's a little more instructive as a result. This also keeps us from rubbing on areas that have damage. This way it remains sensitive. You want to give it time to heal. There are a few other feedback loops. There's a feedback loop within the trigeminal ganglion itself. So the trigeminal ganglion houses a whole bunch of neuron cell bodies, and they're intermixed with satellite glia. These are kind of like astrocytes, but they're outside the central nervous system. So we're still peripheral at this point. We haven't made it into the brainstem yet. So in the trigeminal ganglion, there's going to be local release of neuropeptides. Same story. When they're stimulated, they release neuropeptides out there in the periphery, but also in the trigeminal ganglion. We're not stimulating immune cells there, we're stimulating satellite glia. So we're stimulating that peripheral astrocyte. And it's going to release inflammatory factors like prostaglandins that will stimulate the nociceptive afferent, further driving its activity. This way, pain lasts longer. So we got a few different sort of local positive feedback loops out there in the periphery at the axon, but also at the cell body, in the ganglion itself. So this is exciting the axon down here with the mast cells, and we're exciting the cell body up here in the ganglion. And that robust activation of the primary afferent is going to lead to peripheral sensitization. In peripheral sensitization, the primary afferent increases its expression of sodium channels, so it's more excitable. It's also going to increase its expression of CGRP and substance P. Those neuropeptides that it spits out to say that there has been tissue damage. So this increases the communicative properties of the primary nociceptive afferent. This makes it more excitable and better at exciting its neighbors. Again, increasing nociceptive signaling. Pain is all about robust signaling. You don't want to kind of know when you have an injury. You want to know. You want to protect that injured area. All of these work together. So all of this so far has been for the primary afferent. But you see similar things going on in the central nervous system as well. And that'd be central sensitization. Folks argue heatedly about what to call this, whether it's actually LTP or not. It is. Because we have a greater than 30-minute increase in excitability of the synapse. That's the definition. But anyway, folks like to argue. Because if you make up the name, you don't want someone using a different name. So here's our primary afferent. Here's the secondary afferent, believe it or not. So presynaptic, postsynaptic. So we're in the spinal nucleus of the trigeminal, right here. So when there's pain, we stimulate our primary afferent. We still have the axon reflex. We still have that positive feedback loop with satellite glia. We still have peripheral sensitization, but now we are going to see central sensitization, where we increase the strength of this synapse. So not only is our primary afferent getting more excited with persistent input, the central synapse is going to get stronger, allowing for easier activation of that secondary nociceptive afferent. This is very similar to kindling. Persistent coactivation of your pre- and postsynaptic neuron is going to increase the strength of their synapses with each other. It's just that simple. This is how we learn. Here's learning in the context of pain. When you have an area that's been injured, you're going to have robust activation of the primary afferent. You would like to protect that area from further damage. You want to make it sensitive to additional sensory input. So you can tell if something's rubbing an injured area, and you don't want that to happen. This is going to create allodynium. So, burst firing here is going to cause the release not only of glutamate, but of those neuropeptides. You need burst firing for that. More details next semester. Just believe me. Glutamate is going to act on AMPA receptors, of course. But if we actually have strong activation of our trigeminal thalamic tract, then this secondary afferent should be firing action potentials as well. It should be depolarized, and we should also have activation of NMDA receptors. When we're thinking NMDA, we should be thinking robust calcium influx. This cartoon agrees. When we have calcium influx, that's going to activate a variety of kinases. Here they're putting protein kinase C, that's great. We're going to eventually lead to gene expression. That's what matters. We will talk about protein kinase A and C next semester, because they're really important. They underlie learning, and that's why you're here, right? We have a change in gene expression. We're going to increase the expression of glutamate receptors, for example. So now we have a greater number of AMPA receptors here. So when we spit out glutamate from the primary afferent, the secondary afferent is far more likely to be excited. That change in gene expression is facilitated by the activation of CGRP receptors, neurokinin receptors, which bind substance P. They also will stimulate PrEP-dependent gene expression. So the combined action of glutamate through NMDA receptors and those neuropeptides strengthen the synapse between primary and secondary afferents. Same thing is going to happen in the thalamus. When you have coincident activation of your secondary and tertiary nociceptive afferents, you get LTP. The exact same thing is going to happen. Whether you want to call it central sensitization or LTP or both, it doesn't matter. You're still going to have an increase in painful sensation. So what underlies the abnormal activation of the trigeminal nerve? It depends on the type of headache. That's what it boils down to. In the case of migraine, it appears that there are changes to the primary afferents themselves. Hopefully we recall from Monday that there are heritable mutations in potassium channels that are expressed in these primary afferents. Here it's going up to the dura. So here's our primary afferent, secondary afferent, and they're not showing you the tertiary going to the cortex to actually produce the perception of pain. So mutations in our primary afferent that increase their excitability are going to make them more prone to become active. And that persistent activation of our primary afferent can then lead to central sensitization, making it more likely that we're going to experience headache in the future. So it could be an increase in the excitability of the primary afferent. That seems pretty good for migraine, at least some cases. There are many ways, of course, to increase excitability of neurons. Don't believe me? Go back to the epilepsy lecture. So there are many different types of heritable mutations associated with migraine, but clearly there is heritability. I want to go down to cluster. This is also heritable. There's clear heritability there. This seems to be more central than peripheral. Here it's an abnormality in the hypothalamus that leads to abnormalities in sleep, since your hypothalamus drives circadian rhythms. It also leads to some abnormalities in autonomic function. And the hypothalamus is connected directly and indirectly via the periaqueductal gray to the secondary afferents in the trigeminal thalamic tract. So the hypothalamus can directly stimulate our secondary afferents down here. So when you have abnormal hypothalamic activity, that drives abnormal trigeminal thalamic activity and creates headache. You can actually see abnormal hypothalamic activity during a cluster headache using neuroimaging. And guess what? It's unilateral, just like the headache. Tension headache is a little different. When we think tension headache, we think muscle tension. Usually it's caused by stress. We don't all carry it well. Let's carry it more in our neck, shoulders. Let's think about how that might affect the trigeminal thalamic tract. Muscle tension, muscle contraction. That's not free. Nothing in life is free. What? Muscles are red. That's about all I know about muscles. They contract. Don't ask me any more than that. That is, of course, dependent upon input from motor neurons. That's going to drive depolarization. It's going to cause calcium influx. You're going to get a little troponin, tropomyosin, allowing for actin-myosin interaction, facilitating contraction. When you do this, guess what? We're burning ATP. No surprise there. This is going to stimulate glycolysis, which is, of course, the first step in the breakdown of carbohydrates to produce ATP. All on board? Haven't said anything wrong yet. Glycolysis. How does that affect pH? Oh, yeah. Increases acid, lowers pH. For a few reasons. It might have something to do with the production of lactate, maybe. More likely it has to do with using up oxygen, producing carbon dioxide. Lowering pH, what does that have to do with nociceptive afferents? Can they sense acid? Oh, and does it activate them? Ah, there we go. So when you have chronic muscle tension in your neck and shoulders, I know my anatomy, in the right area, that's going to lead to hyperactivation of nociceptive afferents there. Because you're going to be dropping the pH. It's not magic. It's biochemistry. It's kind of magic. Those, of course, feed into the spinal nucleus of the trigeminal. And that makes you feel that dull, kind of widespread ache that maybe you've experienced before. I guess about 10% of people escape it. I don't buy it, but I read it somewhere, so it's true. Very different underlying mechanisms. Same end result, activation of the trigeminal thalamic tract. You could do it with poor posture, poor coping mechanisms of stress, whatever it is that's leading to that chronic muscle tension. It's burning up your oxygen and producing carbon dioxide, causing a local drop in pH. Muscle activity can affect local pH. It could be because of abnormalities in the excitability of your trigeminal nociceptive afferents. That seems to be the case in migraine. And it could be because of abnormalities in hypothalamic activity. That seems to be the case in cluster headache. All roads lead here. The spinal nucleus of the trigeminal. And from there, you stimulate the thalamus, and then, ouch, headache. Treatment is fairly similar between types of headache. Of course, tension headaches are going to be far more responsive to NSAIDs, painkillers like acetaminophen, which is probably still an anti-inflammatory in the central nervous system, but that's debatable. Exercise seems to help. Nothing wrong with it. No reason not to do it, unless you have an injury. Hell, don't ask me, because I know. You guys know more than I do when to exercise or not. Serotonin agonists, triptans. These are used in more severe cases of headache, where just a little ibuprofen doesn't help. And that's because trigeminal afferents have serotonin receptors. And, of course, 5-HT1 receptors are inhibitory. We'll talk about them next semester. You'll know the difference between 5-HT1, 2, and 3. Pretty straightforward. But these are inhibitory. So when you activate them, you decrease activity in the trigeminal thalamic tract. They work peripherally. They also seem to work centrally as well. So they're useful in migraine, cluster headache, presumably tension headache as well. I don't know how often it goes to that. Botox injections. Sometimes you have to resort to that. Lidocaine can be used, so you can squirt lidocaine into the nose and help cut down on migraines. There's some pretty nifty YouTube videos out there to show you that one. Nice. Deep brain stimulation in the hypothalamus. That'll help with cluster headache, of course. Now that, yeah.
How does the ear piercing, the tragus, isn't that supposed to help with migraines?
I have no idea. Is it?
Yeah, it's like this ear piercing
Nice.
that's supposed to, whenever you get it done, people who get chronic migraines or just headaches, they say they pierce them.
Oh. What's it called?
Tragus piercing. Yeah, tragus piercing.
What is that? Tragus? It's not in the brain. I'll see what I can find. So here we can see just meta-analysis showing you that triptans are effective, whether you have mild or moderate to severe headache. Pain-free at 2 or 24 hours. Forest plots, yeah. Excellent. Yeah, so we can see, here's our diamond, right, 95% confidence interval. It goes to the right, that says that the triptan helped. And it did, in almost every study. In some cases, it's only a slight positive effect. Wasn't statistically significant here, but if you look at all of them together, it seems all right. Any questions? Yeah.
So on the quiz, that one question that was false about the triptans for said for chronic. It said that you could use it to treat chronic headaches, but on here it says acute. So can you also use it to treat chronic headaches?
Show me what you're talking about, so I can actually see it. Okay. I wouldn't be surprised if I wrote something incorrect. Anything else?
I think it says triptans acutely reduce headache at
True.
But it's not for acute
Oh.
headaches.
Absolutely, yeah. With that, you want to go just NSAID painkiller. But with chronic headaches, then we'll resort to this because serotonin receptors aren't just on trigeminal afferents. But it does provide acute relief for the headache. If I worded that oddly, point that out so I can correct it. Sometimes I don't like it.
So as someone who's taken a triptan before, is the serotonin receptors on other places why you get some of like the harsher side effects?
Absolutely. Yeah, serotonin is used widely throughout the nervous system. And a lot of drugs that are going to target neurotransmitters are going to have a wide range of side effects. Undoubtedly, that's the cause there. Yeah. All right. Well, I have a few questions. We'll see if we can get through these. I have my doubts.
I also have another question.
Yeah.
So in the like book notes this is given for preventative, why would that word
And I tried to find a little bit more.
Yeah.
So, I mean, the beta blockers will certainly affect vascular, but they will have other effects as well. And that's because beta adrenergic receptors are also expressed kind of widely. I couldn't find anything about on but maybe really hard. That would make sense. Because beta adrenergic receptors are excited towards the and so so that might be a lot of difference not yeah, a lot of treatments that we have are accidental. You know, like why do we use lithium? Try it. Yeah, exactly. A lot of it is accidental.
I'm on a beta blocker as well, and they were like kind of like for that, like other medications that like you have for migraines, like even like in the
Yeah.
see that there's some
I'll give it another one.
okay.
Yes. Huge. Yeah. Oh. Hi. Okay, we don't have a lot of time. What does the trigeminal thalamic tract have to do with headache? Everything. Oh, thank you. All right, you're dismissed.